So we'll continue on tendons. Jennifer, what do you think of this case?
All right. Well, here it looks like we're looking at the first MTP joint, and kind of distal to that sesamoid, there's some increased signal, I guess, in the plantar plate or the flexor tendon. So I'm concerned about an injury, and there is an effusion.
Yeah, so there's a little bit of fluid here. Here. Fluid there in the tendon sheath.
Okay, so here again, we can see they placed the marker next to that great toe, and we can see fluid again in the flexor hallucis tendon sheath.
And this is a patient who had Tenosynovitis of that tendon sheath, which was actually causing their symptoms. Michael?
Okay, 48-year-old male, 2 months status post-surgery for flexor hallucis longus dysfunction, now with foot numbness. Okay, so I'm, kind of anterior to the Achilles tendon. I'm kind of seeing this, circumscribed area of increase. Yeah, right where the arrow is. So I'm wondering if this is a nerve, like a big edematous nerve. That's what it looks like. So assume something got injured during the. Is it actually? And then we see edema here, kind of surrounding the flexor hallucis longus. So is there a nerve transection, and that's like retracted in edematous? So yeah, what I'm saying, what you're trying to show here is that it's absent.
There's the distal end.
And so the distal end of a transected tibial nerve.
And then we saw it reconstitute more distally there. Right. So this was a transected tibial nerve. And there you can see it there. Now let's go on to the first metatarsal phalangeal joint space. And this is a very common area of injury, as you all are aware of. And there's kind of complicated anatomy here around the sesamoid bone area. This would kind of be the sesamoid bone itself. Remember, wherever you have soft tissue and bone interfaces, the body normally has cartilage in those locations. So this is the flexor hallucis longus tendon. Right around the sesamoid, you'll have cartilage on the tendon to allow smoother gliding through here without friction. And then distally here we have a fibrocartilage before it, and then we can see the joint space here, the phalanx of the metatarsal head, and so forth. We'll talk more about these later. So here, looking more at the gross anatomy that we would see, there's the extensor hallucis longus tendon above. There's a capsule down here. There's the basically the metatarsal sesamoid ligaments, a medial and a lateral one, and the sesamoid phalangeal ligaments down here, and then the articular cartilage. And the flexor hallucis longus comes down here on the plantar side and then attaches distally, as you all know. If you look in the coronal plane, which we often look at, dorsally here you can see the extensor hallucis brevis, which is extension of the extensor hallucis longus. Here's the brevis here. This is the longus up there. Here we can see the collateral, the ligaments on either side, which are the metatarsal sesamoidal ligaments. Then the intersesamoidal ligament here, the flexor hallucis longus tendon coming down here between the two sesamoid bones, and then there's the lateral and medial sesamoid bones. Now there are a number of muscles that attach to this complex to make sure that there's proper motion. With a lot of complex activity. There are the adductor hallucis muscles, basically laterally here, flexor hallucis brevis, and then you can see the adductor hallucis coming in through here on this side. So in this complex of the sesamoid bones, there are a number of muscles that attach to the sesamoid bones to try to make sure that you have full control over the motion of these bones and the metatarsal phalangeal joint space here. And then in the gross specimen, this is the metatarsal head, this is the proximal phalanx, this is the sesamoid bone down here, and here we can see lateral medial sesamoids, the metatarsal head, the proximal phalanx in this location. This is opened up from above and then they're flipped. In this case, we see degenerative changes of the metatarsal head, which you're already seeing in a lot of MR scans are very common. These focal areas of chondromalacia, the metatarsal head. It's much more common on the head, less common on the proximal phalanx. And then we've got the two sesamoid bones, and then the flexor hallucis longus tendon would come in through here. On high resolution MR scan, we can see the lateral medial sesamoids here. This is the intersesamoidal ligament or partial volume in the flexor hallucis longus tendon on either side here in the sagittal plane. We can see the articular cartilages of the first metatarsophalangeal joint. This is the metatarsal head. This is the phalanx. And here's the flexor hallucis longus coming down through here. And here's the extensor hallucis brevis tendon up above. And then here's the ligament between the sesamoids and the proximal phalanx in that area. And again, the intersesamoidal ligament, flexor hallucis longus, lateral and medial sesamoid bones, and then these are the metatarsal sesamoid ligaments on either side, extensor hallucis longus, extensor hallucis brevis. Now, one of the big issues that you can get here is turf toe, really made famous after they put artificial turf on football fields. But it's basically a tear of any of these structures that are meant to stabilize the metatarsophalangeal joint as well as the sesamoid bones. So here's a torn sesamoidal phalangeal ligament right here. This is on the medial side. This has been torn, and that's one of the most common causes of turf toe. And here you can get retraction of the sesamoid bone. One of the plain films findings you can see is one or medial or lateral sesamoid, one of them being more proximally positioned than the other. But you can also, here's a tear of where that ligament is attaching to the medial sesamoid in this location. In this case, there's also a lot of increased signal intensity within the intersesamoidal ligament. So here we've got the sesamoid phalangeal ligament torn over here, the intersesamoid ligament as well, and primarily involving that medial sesamoid. Here's a college football player who had pain on the first metatarsophalangeal joint. What we can see here are muscle tears or strains which are producing the pain. I believe this is medial, and this is going into the medial sesamoid bone in that location. And here we're going a little bit more toward the midline. We can see there's also a tear of the sesamoid phalangeal ligament as well on that side. In the coronal plane here, with this, we can see that there is a tear of that sesamoid phalangeal ligament and a dislocation laterally of the sesamoid complex due to the instability and the tearing. And that's the brevis tendon that's torn. And we can also see the hallucis longus, flexor hallucis longus tendon is torn where it should be here in between the two sesamoid bones. So this was an acute injury producing turf toe in a football player. And then here are just some other examples. In the axial plane, we can see a tear of that sesamoid phalangeal ligament in that location. And we can see the collateral ligaments and capsule are still intact. And another thing that you can commonly see, but it's not necessarily in turf toe, are trauma to the sesamoid bones, which you've all seen, where you get edema within the sesamoid bones. The important thing with MR is to look to see if there are any soft tissue injuries. Typically, edema without obvious cortical fracture of the sesamoid bones is something that can be treated conservatively and has a good prognosis. Here we can see tears of that phalangeal sesamoid ligament. Okay, Michael, what do you think of this case?
Okay, so we see it looks cystic on these images, some cystic structure just immediately inferior to the first MTP joint. From what I can tell, the the volar plate, from what I can see, actually I'm not really sure what level we're at. So now we can see that there's some fluid going, kind of towards intra-articularly. So I think that's at the level of like the intersesamoid ligament. So there's at least some perforation of the volar plate, creating a cyst underneath.
Here we're getting to the actual sesamoid bones.
So here are the sesamoid bones themselves.
So this was a tear of the plantar plate, but it was more longitudinal tear. So here we are. Yeah, this is more proximal, and then that's a cyst, and here you can see the tear, and you're right. This is the intersesamoidal ligament that's torn there, and then we can see it's kind of a longitudinal tear going into that location. At this point here, we actually see that a large part of the intersesamoid ligament is still intact, however, and we don't see splaying of the sesamoid in the bones. Okay, Ashu, what do you think of this case?
All right, so this is an elite Australian rules footballer with great toe pain. I kind of see that bipartite medial sesamoid, maybe.
Okay.
And
this is the symptomatic side, and this is the asymptomatic side.
So, yeah, and there's some soft tissue swelling there along the medial aspect of the first MTP joint. And there's okay. And there's a differential distance between 1 and 2, which may mean that there may be a.
Actually, I'm sorry. I think this is the symptomatic side. This is the asymptomatic side. Sorry.
Okay. Yeah, that makes more sense because there is retraction of the medial sesamoid as compared to on the other side as compared to the left side. So there might be a tear at the proximal phalanx of the plantar plate, or the sesamoid ligament to the plantar. Yeah, there we go. We have an avulsion tear of the medial plantar plate. So that makes more sense.
Good. Good. Okay, and then here's kind of an axial view, and here we can see a lot of increased signal intensity with injuries. So the things you typically look for are fractures of the sesamoids, phalangeal avulsion of the lateral. Oh, this is in this patient. Sorry, open, and they went and did open repairs of these injuries. Okay.
Ballerinas and long-distance runners are the most common individuals to have these problems.
Thanks, John. I didn't know that.
All right, so here is a 38-year-old male with toe pain after rolling the foot, and we have 2 sagittal images through the great toe, and we can see there's disruption of the distal sesamoid phalangeal ligament with fluid signal intensity. It looks like a complete tear and retraction of the sesamoid, and there is some separation between the sesamoids as well, so they may have torn the intersesamoid ligament. Here we can see again fluid and increased signal intensity. The sesamoid, yeah.
And that's the medial one, right?
Medial, right.
That's the most commonly injured one. And the lateral doesn't get injured very often. Is that your findings, John?
Yes.
Okay. So what I'm seeing is, I think I'm seeing some kind of edema and increased signal along that lateral aspect of the first MTP joint. Signal right there, exactly. And that looks like that might be muscular and tendon. I don't know if the medial collateral ligament's involved. Yeah. Okay, and so here we can see that there's a tear of that, the lateral sesamoid metatarsal ligament.
Right.
So that's what we were seeing, kind of that capsuloligamentous tear.
That's you.
Here we can see, we're looking at the plantar aspect. It looks like there might be a defect within the soft tissues and significant soft tissue edema along the plantar aspect of the foot. And I'd be worried about an infection here. And this patient's diabetic, so concerning for cellulitis. And you can see the defect, and you can see the edema kind of extending into the muscle, actually, the first MTP joint even, and along the plantar plate as well. I'm not quite sure what we're looking at here.
What is that hole in the base of the foot?
I think it's a ulcer, soft tissue ulcer.
Thank you. I kind of figured that.
So what's this thing right here?
Is that the flexor hallucis
No, this
muscle,
is actually,
or is that the plantar plate?
yeah, this is the second digit here.
So is that a flexor tendon that's ruptured and retracted proximally, or is that part of the plantar plate?
This is it also. Well,
Oh, okay.
yeah. This is a rupture of the second flexor tendon, and this was all infected. And one of the risks when you get an infected tendon is rupture. So right. So this was this was an infected diabetic ulcer, which then got infection in the second flexor tendon sheath, and ended up with a rupture of the tendon. Okay.
Alright, so we have third MTP joint pain after athletic injury. We have two sagittal images of the forefoot, and it looks like there's dislocation of the proximal phalanx of the third toe relative to the metatarsal head, and I do not see that plantar plate very well. There should be a complete tear of the plantar plate and dislocation of the proximal phalanx, and here we can see thickening of that, probably the looks like third digit flexor tendon, so it's retracted and thickened and from the rupture.
The rupture of the third flexor tendon and from the dislocation. Good. So here's a football injury, pain at the metatarsophalangeal joint.
Football injury, pain. So we see kind of irregular signal, low intensity signal in the plantar fat underneath that second MTP joint, and there's signal within that flexor tendon as well. So, but it looks grossly intact. So I'm wondering if like part of the plantar, like the volar plantar plate is injured, but like the tendon itself, I think, is grossly intact.
There's a portion Philip thought was torn, and they actually went in surgically and repaired a tear. But it does look like some of that flexor tendon is intact, but there are segments here. It doesn't look like it's centered over the bone, so I think some of the surrounding stabilizing attachments were torn.
Yeah, it's subluxed.
Yeah, subluxed, right. Ask you.
Okay, well, here we can see that there is a displaced fracture of the second MTP joint. I think mostly the proximal phalanx there. And there's a lot of edema there. And there's complete disruption of the plantar plate and inferior dislocation of the second metatarsal, and significant edema there.
Yeah, or dorsal displacement of the phalanx, and this again was a complete plantar plate tear. Okay.
Anterior is acceptable, of course.
Yeah.
We have a 37-year-old male with toe pain, and we're comparing the painful side to the non-painful side. I can't tell if these are T1 images. There's definitely an effusion that's asymmetric on this side, and then I see that flexor tendon is displaced from the distal aspect of the proximal phalanx. And here we can see again there's some fluid signal intensity and displacement. So this looks like a plantar plate injury. Pulley.
Yeah, this is called a pulley tear, and there are definitely pulleys, which we haven't talked about yet, in the fingers, which keep the flexor tendons from bowstringing when you flex your fingers. It's still controversial whether you have similar pulleys in the toes. Some people believe that you do, some people believe you don't. And I don't know enough about the details of anatomic dissection to know why that would be controversial. You'd think it'd be pretty straightforward, but it still is controversial. But we can see that there is some differential separation between the flexor tendons on one side and the other side, and the side where it's displaced is the painful side, and the marker was placed right where this occurred. So
Clawing of toes and so on, they frequently need attention surgically.
okay.
It's these are not every tendon is useful in the foot, so don't you just don't throw them away. The long tears are helped by the extensor brevis tendons, and so every tendon is important. You fuse the toes, then you transfer tendons, and so on. There's many different procedures to take care of the foot. It's amazing how many have appeared since I've stopped doing surgery.
Thanks. So let's now talk about the anterior tendons, the anterior tibialis, extensor hallucis longus, and extensor digitorum longus. These come down underneath the extensor retinaculum. There's a superior segment here, and then we can see the kind of Y-shaped mid and distal segments of the extensor retinaculum. And these obviously keep the extensor tendons from bowstringing upward and keep them pulling in the correct direction. Now, if we look at the tibialis anterior tendon, it comes down, and where you have the extensor retinaculum, you have a tendon sheath here to allow the tendon to slide normally beneath the extensor retinaculum there. So this is just the tibialis anterior tendon is not in our typical sagittal plane. Proximally, we'll see it more toward the midline. And as we go distally, it comes more and more medially until it comes down, and one of its attachments is here on the medial bone here. Like so many tendons that come down, it can have multiple attachments here, but the medial cuneiform is its primary attachment most of the time.
Not as many as the posterior.
Yeah, right. Exactly. Michael, what do you think here?
So we have soft tissue marker overlying one of the anterior tendons, which I assume is anterior tibialis tendon.
Right.
And there's all this, soft tissue signal around it. I don't know if it's just a cut on the sagittal, if it's torn or not. If not, this might just be like marked tenosynovitis.
Tenosynovitis. And there might be a little bit of tendinosis or tendonitis here with the indistinctness, but a lot of this is just fluid around it. This is a patient who had rheumatoid arthritis. Thank you. Okay, Ashu.
Here we can see, I think this is focal fluid signal of the anterior tibialis tendon with splitting of the tendon. On the axial, though, there's not a full longitudinal split. I think this is just a focal tear of the anterior tibialis tendon.
Yeah, so this was a tear with just some proximal retraction, and obviously it was a tear into an abnormal tendon. As we talked about before, has been shown in the shoulder. These tendons, normal tendons, don't tear. It really requires either something like a sharp edge to cut it, or you get a tear in the underlying tendinosis within the tendon. Hate those garbage cans.
So he fell 1 month ago and hit his ankle, and his wound was stitched in the ER. Persistent pain and lump. It looks like a full thickness tear of the anterior tibialis, kind of near the proximal aspect of the medial cuneiform with navicular with retraction to the level of the distal tibia. And here we can see the retracted tendon with surrounding fluid and edema.
Yeah, this is something where MR is used not infrequently, well, maybe not very frequently, but infrequently, where people will come in, they really don't do a good tendon examination, don't realize that you have a tendon tear, and then they sew everything up thinking they've taken care of it. But then you have to go back in and operate to repair the tendon abnormality. And if you wait too long, it scars down, making it very, very difficult. So
they scar down even if you operate on them. That's one of the problems. So you operate on these, and then you have to be very observant on frequently to make sure that they don't scar down. It's one of these injuries that you have to carefully watch over a period of time until they're healed.
Thanks, John.
Okay, so we're at the level of the distal tibia, soft tissue marker anteriorly. So in the first image, I see all three tendons, and then on the second image, the extensor hallucis longus is now missing. So this image of extensor hallucis longus tear.
Okay, I think we're overlying the extensor hallucis longus here. There's a lot of increased signal. I do not see continuity of the fibers. I'd like to see a stir image, though. A little bit of motion artifact, but I think there's a distal tear here of the extensor hallucis longus tendon. We can see a lot of edema here.
Yeah, so this is kind of a distal mid-substance tear of the extensor hallucis longus. Good.
Okay, so here we have some more sagittal images through the great toe, and it looks like there's a complete tear of the extensor hallucis longus. And here we can see it disappears, and there's fluid signal, and then it's reconstituted here. Okay,
Fisher, slipped on water, rule out extensor hallucis longus here. So I believe I see the extensor hallucis longus, but it does look maybe a little off center in relation to the MTP joint. So So next cut, I don't see it. Okay, I don't see it here either. So I believe it is torn distally.
Right, got a complete tear with a little bit of retraction. Yeah. So there's the extensor hallucis longus where it originates. It comes down to the anterior part of the ankle all the way down. And it's basically the kind of the terminal tendon that we will see in the hands attaching to the dorsal base of the distal phalanx. Ashu.
Are we looking at the extensor digitorum at this point? There's some fluid underneath it. This might suggest some tenosynovitis.
Good. Great. Okay.
Okay, so here again we're looking, there's two soft tissue markers along the extensor digitorum, and it looks like there's at least some partial thickness interstitial tearing. Maybe on the sagittals it almost looks like there could be a full thickness component. I'd want to follow it down and see if it's full thickness distally. But
It was a partial tear with tenosynovitis.
Okay. So there's just marked thickening of one of the anterior tendons, like extreme thickening. It looks low signal intensity. I don't know if that's field artifact or if that's real signal right there. Okay, so now we see all this kind of stipulated increased signal throughout that tendon and muscle. This almost has a look of, I don't know if it's that, but like in the Achilles when you see like xanthogranuloma, it kind of
Almost looks like there's some chondromatosis on that right image. Yeah.
So these are kind of foot nodules in the synovium around the tendon. Here's the tendon here. So this actually turned out to be chondromatosis, as John said, and the differential would also be rheumatoid nodules and rheumatoid arthritis. So, okay, and then there's the Achilles tendon posteriorly. So you can have tears, either non-insertional or insertional tears. So the location is important concerning thinking about treatment. And then there's there are different types of pathology which can lead to tears or not lead to tears, or non-tear pathology. You can get type 1, which is inflammatory changes, type 2, where you get a lot of degenerative changes, type 3, you get partial tears, or 4, complete tears. This really is kind of the Wonstabe classification system. It's kind of old. I think what's better, instead of this kind of concern, I think it's better to look at these different stages as being kind of early tendinosis or very grade 1 kind of partial tears like we see in other tendons. Grade 2, you get much more extensive increased signal intensity within the tendon, degenerative change. Then you can see partial tears and then a complete.
I read that journal many, many times, John, and I never used this.
Yeah, good. Okay, so here is the Achilles tendon coming back here, but let's see. Ashu, what do you think of this case?
Looking at this case, see some signal kind of right within the retrocalcaneal area, right where the tendon inserts, and there's a posterior subtalar joint effusion. I don't see a Haglund deformity. There's some edema also within Kager's fat pad. So I think this is more of a peritendinitis picture.
And you really should have fat here. You can see the fat's been very much replaced. So this is peritendinosis. And you can sort of say itis, but this typically is fibrous tissue rather than an acute inflammatory type tissue, but it may be secondary to chronic inflammatory disease. Most of the changes here, occasionally it could be from infection from penetrating injury, but most of the time it's probably from trauma, maybe hemorrhage with a little bit of fibrosis, but this is called, most people call it peritendonitis. And I think this is what I would put more in the type 1 category, where the tendon is really in place, but you've got fibrosis and maybe inflammatory changes in the grace.
Is that spelled correctly?
What, John?
Is that spelled correctly?
Yes.
I thought it was peritendinosis.
No, it's peritenon. It's not tendon. This is peritenon.
Sorry about that. Well,
I much ado about nothing, I think, but
yeah,
the purest.
I just want.
Yeah. Okay. Let's see.
Okay, so it does look like there is some increased signal in the mid to distal Achilles. I don't see any definite tear or retraction, but there's surrounding subcutaneous edema. So this looks like tendinosis or peritendinosis.
These are, again, I think more probably from trauma. Most people would call this a peritendonitis in this area, right? And then, John, to your point, purists kind of like to reserve tendonitis to those tendons who have a tendon sheath. The distal Achilles does not have a tendon sheath. The surrounding tissue attached directly to the tendon, so the surrounding area around the tendon is called the peritenon rather than the tendon sheath.
I've never used that in the past, so I'm
not sure it's necessary.
This is new to me.
Yeah.
What we do when we repair these, we use the Plantar stent and make it, synovial tissue out of it, and cover the incision and repair site with a split tendon. You can stretch it like a harmonica out of that tendon, and then make it like a cigarette paper, and then cover the repair site so that it's smoother. It's just something popped into my mind, and I'm talking about.
Thanks, John.
Okay, so here we have kind of marked fusiform thickening of the mid-distal Achilles tendon with increased intersubstance signal. I think the Achilles tendon, it looks like we're showing on that last image that it's intact to its insertion on the calcaneus. So I just call this tendinosis. Maybe there's an intersubstance tear.
There's a lot of tendinosis here. There's an interstitial longitudinal tear in this, and it's not a high grade tear, even though there's a lot of tendinosis here. So this would be kind of a low grade degenerative tear, kind of a type 2 type tear. Ashu?
Here we can see quite a bit of increased signal involving a very tendinotic distal Achilles tendon. This looks like more of a moderate partial tear of the Achilles tendon.
Yeah, so this is a higher grade tear. And generally people say if it's over the 50% of thickness, then you're talking about high grade, both in the shoulder and other tendons. So this would be kind of a type 3 in this category.
And that's what's interesting is the different typing, but the treatment is all the same.
Yeah. So typically, when I dictate it, I don't put in types. I just describe it and say roughly the percent of the tendon involved. I don't want.
If you dictated the types, you would confuse orthopedic surgeons. You know we can only stand so much knowledge, John.
Okay, knowledge overload.
All right. Here we have two sagittal images side by side of the ankles, so we can see that there's asymmetric thickening and increased signal in that right Achilles. I want to evaluate it distally to see if there's a tear end retraction.
It basically just comes flag and goes into the Achilles. So this is another involvement, and roughly 50% involvement of the tendon by abnormal signal intensity, but a lot of widening. So there's a lot of tendinosis here, and probably a moderate grade partial tear.
Okay, so there's a pretty well-defined defect in the posterior aspect of the mid-distal Achilles tendon with maybe few intact anterior fibers. This makes it look like it's kind of transected vertically.
How do you think that happened?
So I mean, was there a history of like a laceration, or is this actually something like either it's like a very fine laceration or some reason like it doesn't look like it got torn.
Right out of the cheek.
Yeah, the edges are very sharp. I think it's a good idea to think about laceration. Turns out this wasn't a laceration.
Right out of the Greek history, John.
Say that again?
It's right out of the Greek history.
Oh.
That's where the Achilles comes from.
Right, exactly.
But this doesn't look like a cut because the skin looks okay.
Yeah.
Unless it was from the side.
Right.
I've never seen a tear so sharp.
Yeah, I agree.
It could have been cut from the side.
Yeah, it's what it looks like. And here's just a case who also had symptoms of Achilles tendon problems, but here we can see severe atrophy of the gastrocnemius, and really the other muscles of that one leg are asymmetrically abnormal here. Let's see, Ashley, what do you think is going on here? Actually, you know, that's just this case. This is a chronic tendinosis, probably some partial tearing, but the tendon was intact all the way to the bone. But because of the chronic symptoms and pain, there's a disuse atrophy of the gastrocnemius. Ashley, why don't you take this case?
Okay, here we can see fluid extending through the distal Achilles tendon. I'd like to see the sagittal images, but this would be concerning for a near complete tear. Yep, this looks like a complete tear of the Achilles tendon, a separation of the fibers, mild retraction. Kind of see it on the axial imaging as well.
Yes.
So yeah.
That was a complete tear.
So what'd you do with it?
Well, it's I don't know if you could let it scar down, but it looks like it's.
I would put it in a cast with that ankle flexed into a comfortable position and let it heal.
So treatment for these is very controversial, and it depends very much what part of the country you're in, at least in my experience.
Not in Australia, it's not controversial. And nobody operates in Australia.
Okay, maybe not in Australia, but in the United States, it's very variable. In my experience, on the East Coast, these tend to be operated on. In Southern California, there is less exuberance about operating on these, but a lot of them.
Well, it's warmer in California, and so the casts are, there's a tendency to get more infections probably. I've seen enough skin sloughs. I've seen about 3 of them operated on, and
yeah,
all the way to bone, with no tendon visible, and then reconstruction. And I said that was the last time I'm going to see anybody operate or assist in anybody operate. So I gave that up. I went with Australian.
Okay.
And I've never been sorry about it either, because I didn't care how far there's a retraction. The tendon will slither down as long as you're upright.
So there are some papers that recommend a 1 centimeter distance measuring. If it's greater than 1 centimeter of retraction, then it's operative. If it's less than 1 centimeter, it's treated non-operatively. But I've seen a number larger than that treated non-operatively. What typically a year's time, you'll see that it's contiguous. Generally, the tendon will be markedly thickened, and over the next 5 years, it'll kind of remodel back to more of a normal kind of situations. And as John's talking about, I've certainly seen quite a few that have been operated on that have ended up being disasters. So this is an area that's still quite controversial, and it'll depend upon where you are and how the surgeons are trained in the area you're practicing in.
I've treated, in my career, I've treated maybe 30 or so. And I've never been sorry treating them conservatively.
Yep, I can believe it.
And I've seen guys operate, and I've felt very sorry for them because they were in litigation and all kinds of stuff.
Okay.
Anyway, this is just one man's opinion. John is giving you an oversight, and I could give you the oversight too. But I learned my lesson. Don't. And there's no reason to operate. I just don't find it.
This patient had an acute.
But you're going to have people that are going to be operating, so you got to read their results regardless.
Thank you. Here we have 2 sagittal images through the Achilles tendon. It looks like there's a complete tear about 2 to 3 centimeters from its insertion from the superior aspect of the calcaneus, and I do not see the proximal retracted tendon, so it could be retracted beyond the field of view.
So what can happen in some of these acute injuries is that it actually pulls, and it's a little bit like spaghetti. The force is very great. It'll cause it to stretch, and finally it'll thin out and then pop. And that's what happened in this case.
This you couldn't repair if you wanted to. That's the problem with this one. There's nothing to suture to above. This is right at the junction tear, and my suggestion would be to just leave it alone and cast it.
Okay, so this looks like a full thickness tear of kind of the mid Achilles tendon. And you can see some laxity, down inferiorly.
Okay, Ashu, they wanted to know if the patient had an Achilles tear.
Yes, they do. Looks pretty complete, pretty tendinotic, a lot of fluid there. I don't really see any normal tendon.
What's this?
I guess that might be a little bit of normal tendon versus, is that a focal deposit?
Longitudinal structure that goes up and down.
Okay, so I guess it is some persistent remnant of the Achilles tendon then, right?
That's the plantaris tendon.
Okay.
The Achilles plantaris there. And the plantaris is much, much longer, and so it can give a little bit more.
It's a small tendon, but as I was talking earlier, you can really stretch that tendon like cigarette paper, and it can go all the way around Achilles tendon. It's fabulous to watch. I mean, it's kind of very interesting when you do that.
Okay.
It's almost like it was created for that purpose. That's if you operate on these things.
Okay. So this is 6508. The patient came back, and this is 62608. So, 3 weeks later.
I really don't see any meaningful tendon structure in the region of the Achilles tendon. And there's a lot of scar tissue probably.
You hear the
in this.
axial images. Here's the way
I think you can.
This is the way it was on 6.5.
Mhm.
And here's the way it is 3 weeks later.
Well, on the axial, actually, I think the Achilles tendon is partially healing. I can almost see normal. I see a lot of scar tissue there, but it is healing.
Here's a little bit over a year later.
Wow, it's healed quite a bit. It is thickened, but it looks like just quite a bit thickened, but I don't actually see any increased signal, and it looks like it's healed.
So this is why John doesn't like to operate on these.
This is just how I like it. I'm a conservative guy too, by the way.
So here again, we have some sagittal images, and we can see, I don't see the Achilles tendon insertion well on the calcaneus, and there's additional tearing just above the insertion.
So this is a patient who had a full thickness.
I think John will show it to you shortly.
This is a person who had a full thickness tear and had surgery. A week after surgery, kind of fell on the stairs and came in now with increased pain.
Yeah, so I think that there is, well, I'd like to see the preoperative images to be sure that this is another tear, but it looks like a tear of the Achilles repair. There's retraction. I think that that's surgical material. I'm not sure what type of material, but it doesn't look like it's natural.
So what did John tell you about using the plantaris to encircle the Achilles tendon?
Okay, so this must be a case where they encircled the plantaris around the Achilles, but it doesn't attach to the calcaneus.
Which they call the collagen wrap. It doesn't have to be the plantaris. You could also use other structures as well in this particular case.
Usually we don't use anything around the tendon.
Yeah. And so this is 2 days after the repair when the patient fell down the stairs. And so this was a retear after the...
It's a collagen wrap. I'm not sure it is all that helpful.
I don't remember whether this was allograft or plantaris.
Okay, so rule out Achilles tear. So I do see a tear of the Achilles tendon, kind of mid-distal portion right there. Looks like there's a focal defect. I mean, the portion of the Achilles tendon I can see here looks pretty thickened with increased signal and kind of irregular. It's 11-12-08.
What's that?
Coming under right there, that'll be one of the, which one is that? That's not the posterior tibialis tendon? Or flexor hallucis longa, okay.
So that's on 11-12-08. This is after surgery 4/15/09.
Okay, well, there's a suture anchor that's just kind of sitting there in the Kager's fat pad. So I assume that was initially in that defect we can see in the calcaneus. So they sutured something down, and now that's popped out. Status post, the coronal plane, I don't see any meaningful repair. The flexus hallucis longus transplant, they took that. Correct?
You can see it's torn.
It's torn there.
Where's the Achilles tendon?
Oh, I don't really see it.
They then tore their flexor hallucis longus tendon.
I don't think using that screw is a good idea.
No, it wasn't in this case. So I'll show you some other examples when John doesn't like to operate on these. Ashu.
All right, so here we see cadaver graft repair on April 9th, now 10 days of swelling and pain. We can look, I don't really see, you can see post-surgical changes within the expected distal Achilles tendon, but the Achilles tendon, there's a large fluid defect, and I think there might be retracted, on that sagittal image, I think there are retracted Achilles tendon fibers more up there, right there, yeah. So it's like a retear.
That was Retear number 2. Okay, Jennifer.
All right, 54-year-old with surgery 1 year ago and pain for 3 months. So I believe this is a coronal through the Achilles, and there's a fluid collection along the distal Achilles. And here it looks like there's a tear kind of along the mid aspect of the Achilles with surrounding fluid. I'd be concerned about chronic infection if they have it.
You can see here the surgical places. One of the bow tenodesis screws here is still intact, but we can see that there's really a tear of the soft tissue construct up here with a lot of hemorrhage in here with different signal intensities within the fluid. But the soleus component is still intact, but the gastrocnemius part is torn. So why don't we stop here, and we'll talk about insertional tendinopathy tomorrow. Okay?
Thanks, Dr. Cruz.
Yep.
Have a great one, everybody.
You too.
All right.
That's getting